Recently, I had to do a lecture in Crete for some of your colleagues, and this is largely overlapping with that. So I do apologize for that, but I had this lecture already ready for you for quite a while. So I hope it's going to be okay for your audience. So we're going to talk about aortic stenosis and heart failure. What starts actually as a, let me see how I can move my slides here. Okay, this is how it goes. If we talk about aortic stenosis, it starts as a valvular disease, but soon when the pressure becomes too much on the ventricle because the valve isn't opening, the pressure comes too much on the ventricle and secondary LV fibrosis will occur, and that follows actually in heart failure. So if we talk about the burden of heart valve disease, what we see here is that when patients get older, that actually the amount of heart valve disease increases. And you see here actually that when patients get older than 75 years old, they develop a lot of valve disease. And in green is aortic valve disease, which is mostly aortic stenosis, as you see here. And in orange is mitral valve disease, which is mostly in our Western countries, mitral regurgitation. So today we speak about aortic stenosis. So if we talk about the setting of aortic stenosis and heart failure, we get ourselves in trouble because often these patients present with low flow, low gradients. That means that my aortic valve area is very small and the valve doesn't open. So according to aortic valve area, you would say I have a severe stenosis. If I look at the gradient, however, I don't see that severe stenosis. Gradients are usually very low, maybe 20 millimeters of mercury. So I have a discordant situation that the valve doesn't open, but my gradient is absolutely not high. We then ask ourselves the question, is this something that we see often? And we would normally say, well, not that often. But now, if we look in our big databases, I see in 35% of patients with severe aortic stenosis the situation of a reduced ejection fraction, of a low flow, and a low gradient. Low gradient means more than 40 millimeters of mercury. Still, my valve does not open. So the question is, why do I see 35%? Because if I remember carefully in the past when you discussed with your surgeon that we don't have so many of those. And that is because these patients with a very bad ventricle, they were never considered at all to be treated surgically. They were not even discussed by the cardiologist, or if they were discussed with the cardiologist by the surgeon, then the surgeon did not accept them. But now when we have the option of transcatheter procedures, the whole field changes. And you know that we have this study ongoing, which is called TAVR Unload. This is one of the partner studies, and this study is actually focusing on patients with heart failure, a reduced ejection fraction, but a severe aortic stenosis. I always take these cases, and the cases illustrate best because it's the real world. 73-year-old man, so aging population, 2003 infarction. He's treated conservatively. 2006 angina. He has a low ejection fraction of 20%. Angiography, 3-vessel disease. He gets bypass surgery and ICD. Now he's symptomatic again. He has progressive dyspnea. He does not have angina. He's presenting with progressive dyspnea. So he's in New York class 3. That means he gets dyspnoic on very little exercise. Comorbidities is severe kidney failure, and he has a logistic Euro score of 42.6%. This is extremely high, so patients like that will never be treated surgically. This is the echo situation, and you see here on the top, you see here a ventricle that doesn't function well. There is an ICD lead here. This is a ventricle with a low ejection fraction. This is a valve that we cannot see very well. This is the flow, but what we see very clearly here is that the velocity is relatively low. Now that translates into an ejection fraction less than 40%, an effective orifice area less than 1. So my valve does not open. My mean pressure gradient, however, is less than 30 to 40. So I have a valve that doesn't open, which says severe aortic stenosis, But on the contrary, I have a pressure gradient which is low, so it says no severe aortic stenosis. So we got a discrepancy here. The one says yes, the other one says no. So my question is, and your question is it the valve that doesn't open? So is it a severe aortic stenosis? Or is it the ventricle that doesn't pump and therefore the valve doesn't open? Because we're looking at a patient with a bad pump function. Here you see the algorithm that we've designed for that. So we start out at the top. Here's my arrow. Low flow, low gradient, severe aortic stenosis. That means my aortic valve area is less than 1. That's a severe stenosis. But my gradient is less than 40, so that is not a severe stenosis. This is the situation that we call the classical low flow, low gradient aortic stenosis. What do? We give low dose dobutamine to improve the function of the ventricle. If it is not a severe aortic stenosis, my ventricle will contract better and the valve will open. That means that my valve area will increase. If it is a true severe aortic stenosis, my ventricles start pumping better, but my valve stays closed. As a consequence, my gradient will go up. Let's see what our patient is doing. This is the baseline and the dobutamine. On the top, you see the baseline. As I told you, the aortic valve area now indexed for body surface area less than 0.6 centimeters square per meter square. That's a severe aortic stenosis. But my mean gradient, as you see here, doesn't confirm that. Now I give my dobutamine. You see the ventricle already visually contracting better. And the mean gradient goes up now while the valve stays closed. So this is a true severe aortic stenosis. Gradient goes up, valve stays closed. And this is what I just said to you. You can see here in this algorithm that my valve area is small. My gradient now goes up. So this is a true severe aortic stenosis. However, as I plot to you here on the right in this rectangle, most often we don't see any changes with low dose dobutamine. It's a little bit changing, but it's not diagnostic. So what do we do then? Nowadays, all these patients are being worked up for transcatheter aortic valve replacement. So they will all have a CT scan because you and me and wherever we are in Europe are using now CT scans to do the diagnostic workup of these patients. If I have a CT scan, I will have this also. Here you see the routine CT scan and you see the calcium at the tips of the leaflets. Very, very visible. Here's the calcium at the tips of the leaflets. The commissures, the tips of the leaflets, that is where it is. This is the coronary artery with atherosclerosis for your information. So there have been cutoff values proposed, and that comes predominantly from Canada, from a guy called Philippe Pibarot, who's a really excellent researcher. And they propose that it's severe calcification for men if it's over 2,000 Agatston units, or in women if it's over 1,200 Agatston units. That is all fine, but what about if this calcium score with this patient now would have been 1,900? Would that change your diagnosis? No, because we are clinicians, and that's something that we should never forget, that all the numbers of a gradient, of a valve area, and also of calcifications are just measurements. And at the end, you as a clinician bring it all together. And then you come to the conclusion, whatever this is a severe calcified aortic stenosis. That's what I said. Important is the cutoff values are just an indication, but you as the clinician make the difference. This is an opposite case. This is a 57-year-old female in atrial fibrillation, successful catheter ablation in 2004. Coronary disease, just a very little bit. Right coronary branch, 60 to 70% stenosis. She's obese, but most important, she had breast cancer in 1984, and she got surgery, chemo, and radiotherapy. And her current symptoms are dyspnea class 2 and persistent AF. We ablated, but it came back, as so often is the case, because we're talking here about heart failure with preserved ejection fraction. This is heart failure, but you will see that the function is quite normal. It's the ECG. So it's in between a flutter and a fibrillation, as you see here. Sometimes it looks like a flutter, sometimes it looks like fibrillation. Of course, all the echo measurements when you are in fibrillation or in flutter are not reliable 100%. But this is what you have to deal with also in the clinics. So her ejection fraction is 36%. You see that the picture is not brilliant. I see the valve opening, not that much. You see that? You can see it open. There is a little bit of flow over it, a little bit of backflow also. This is the mean gradient is 14, so it's absolutely not elevated. However, her valve area is 0.57 centimeter square per meter square. And that is a severe stenosis. Okay, we go with the dobutamine. This is the baseline of the woman again. And this is the dobutamine, 20 mics. You see that they start to contract much better. You see the endocardial contours quite well defined, whereas we don't see it that well here. Usually we do this with echo contrast, so you see much better the contours. This is our situation at baseline, mean gradient low, and a valve that is closed. Now I give 20 micrograms of dobutamine. My gradient stays the same low, it's now 20, so it's not much. But my valve area is now 0.72 indexed for body surface area. And that means that this valve is opening pretty well. This is the opposite. This is a pseudo-severe aortic stenosis. When I give dobutamine, my gradient stays low, but my valve starts to open. So this is a pseudo-severe aortic stenosis. This patient has another problem. It's a ventricular problem. It's this heart failure with preserved ejection fraction, probably after chemo and radiotherapy. The valve is partially calcified. You will see not much, but all of that is related to the radio and chemotherapy. Here is the CT scan of the patient. You see a very, very low calcium score, 900. Not very low, but it's not diagnostic. And you see here, if you see the valve, you see the tips of the leaflets. Watch it again here. Here are the tips of the leaflets, and there's very little calcium. This patient does not have an aortic stenosis. She has another problem, heart failure with preserved ejection fraction. From that, we conclude that low flow, low gradient aortic stenosis, you give low dose dobutamine to unmask it, but we nowadays are better off with a CT calcium score. The numbers are important. It's a good guideline, but don't be completely focused on the numbers. I'm going to take you now to this part. This part, I think, is the new research that we are doing. This is the moderate aortic stenosis. What do we know about that? This is associated with impaired survival compared to a matched patient cohort without moderate AS and preserved left ventricular ejection fraction. One study showed that. Another study showed that patients with LV systolic dysfunction and moderate aortic stenosis have an even higher event rate. This is the biggest data that is available. This comes from 241,000 patients out of Australia, but these are not pictures. This is taken from reports from echoes. Out of these 240,000, 25 to 26,000 patients have aortic stenosis, which is 10% of that population. Here I see my stenosis, mild aortic stenosis, moderate aortic stenosis, severe aortic stenosis. And what you see here, if we look at the moderate aortic stenosis, the 5-year mortality is pretty high. So this seems to be not a benign disease. This seems to be a disease which is not good for the patient. So we need to probably start think differently. This is the outcomes again. This is no aortic stenosis over 16 years follow-up. The green is a mild stenosis, but the blue and the black are the moderate and the severe. And you see that there is very little difference between those two curves, but you also see that at 5-6 years follow-up, there is significant mortality as compared to the normals or the mild aortic stenosis. So moderate aortic stenosis is not a benign disease. Now comes our original research. This is 1319 patients coming from our database with moderate aortic stenosis. This is defined as an aortic valve area between 1 and 1.5 centimeters square. There is a follow-up, median follow-up of 4.3 years with a range 2.5 to 7.1. We look for mortality, and we look for mortality, stroke, and heart failure and infarction as endpoints. Now I'm going to take you to something different. It is not just a valve disease. You cannot say, okay, I have a patient here, I take out the valve, that is his disease. But what happens if you have a valve disease? What follows after aortic stenosis? What we see is that myocardial damage starts to occur. We spoke about it already. If there is an obstruction of the valve and the heart is pumping, it has to pump harder. As a consequence, it becomes hypertrophied, the left ventricle. But hypertrophy eventually comes with the formation of fibrosis. So there are consequences here in the middle of the aortic stenosis on the left ventricle, eventually on my mitral valve and left atrium, then on the tricuspid valve and on the right ventricle. I'm going to show that to you in a second. This is a new way of thinking. This is the concept of staging the aortic stenosis disease. We have published it recently also for mitral valve disease. This comes from Genereux. He did it in severe aortic stenosis, published it in European Heart Journal 2018. Initially, the editors were keen to reject it, but I told them this is going to be an important article. This is something that is going to change our way of thinking. We applied this concept to our database. I'm going to show it to you how it works. This works very simple. Here you see the staging in the moderate aortic stenosis. I have a left ventricle here, and I have a right ventricle there. This is my right atrium. This is my left atrium. Here is my aortic valve that doesn't open. So what's going to happen is that this ventricle needs to work harder and harder and harder, becomes hypertrophied initially, but then starts to dysfunction. LV dilatation occurs. If LV dilatation occurs, then this valve is not closing anymore. So mitral regurgitation starts to come. With mitral regurgitation and LV dysfunction comes elevated LV pressures. And then we go to the next stage. Then LA dilation starts to occur. And when LA dilation starts to occur, many of those patients develop atrial fibrillation. And this is what we all know from the clinics. A lot of our aortic stenosis patients start to develop atrial fibrillation. And then we are late. We are too late in the disease process already. If atrial fibrillation occurs, my filling pressures will go up, and eventually the right-sided pressures will go up. So I will develop pulmonary hypertension, and secondary to that, I get RV dilatation, and I get tricuspid regurgitation. Now I get the full circle. Okay, I started with an aortic stenosis. It became a ventricular disease of the left side. The ventricle dilated. Mitral regurgitation was the consequence. My pressures go up, so the atrium dilates. You get atrial fibrillation. Then it spreads to the right side. My pulmonary pressures go up. I get dilatation of the right ventricle and dysfunction, and eventually tricuspid regurgitation, and eventually those patients die. Now we're going to go back to my database of the moderate aortic stenosis. So if we look at all of these patients, 13% is in stage 0. That means they have no cardiac damage, they just have an aortic valve problem. 27% in green here has ventricular damage. Left ventricular damage. That means starting LV dysfunction and LV dilatation. This is very interesting to see. About 45%, 42.5% to be precise, develops LA problems or mitral valve problems. That means mitral regurgitation comes and or atrial fibrillation. 10% in purple here goes in stage 3. Where there is now pulmonary vasculature or tricuspid valve damage. And 7% is in stage 4, which is the in gray, the right ventricular damage. Let's take a look at the outcomes of these patients. This is all-cause mortality. I see here in blue the stage 0. It's just a valvular problem. My 5-year mortality is 22% in these patients. But if they develop stage 1, ventricular problems, or stage 2, or stage 3, or stage 4, you see the mortality going up sky high in 5 years. Now I look at the endpoint of mortality, stroke, heart failure, and infarction in moderate AS, and you see actually here that these rates of mortality plus the other endpoints are reaching almost 100% in stage 4 patients. My conclusion to you is about this, and we're working on more and more on this to get a better idea. Moderate aortic stenosis is frequent. The event rate is high, the mortality is high. So they start to challenge us. Should we intervene earlier? Should we think differently? Should we prevent this valve starting to create damage for the rest of the heart? How do I select then these patients? Probably guided by the staging severity, that I want to treat them when they're still in a low stage. These are all questions for the future. I want to end here, and it was my pleasure to be with you. I hope that you enjoyed this. We know about aortic stenosis. We start to learn about aortic stenosis and heart failure. And with this moderate aortic stenosis, I showed to you how the heart failure relates to the aortic stenosis. It's not just that I have a stenosis and then coincidentally I develop heart failure. No, these two are interlinked. So there is this staging of disease, and I illustrated that very nicely to you in the moderate aortic stenosis. But of course, the same principle applies to severe aortic stenosis. And that was published in this very highly cited paper in 2018 by Généreux in the European Heart Journal. So we need to think differently. And that, of course, is not going to be done tomorrow. That's going to take time before we have trials and implement this in guidelines, etc. But it starts by different thinking. I look at your country. Your country has probably the oldest civilization in Europe, and you have produced the most intellectual thinkers. I think if we start to apply intellectual thinking more to diseases, then we understand it better, we can treat them better, and we can go in the direction of intervention. It was my pleasure to be with you, and hopefully next year, if you still want me, I come to you again. Thank you very much.
We thank you, Professor Bax, for your excellent talk. It's really important to think out of the box and discover things from the beginning. What I wanted to ask you about moderate aortic stenosis and morbidity, whether there was an associated risk for sudden cardiac death among these guys. You showed nicely that there was risk for MI, for stroke, for total mortality. But what about the electrical system of the heart in earlier stages of aortic stenosis, or even in asymptomatic stages of severe aortic stenosis, where the risk of sudden cardiac death is as high as 25% in 5-year time?
Yeah, that's a very good point. And yeah, you asked me that in the beginning. So what my feelings about this are, if you look at severe aortic stenosis, hypertrophy starts to occur in the early stages. If you look at the ejection fraction as a measure of the pump function or performance of the left ventricle, it looks fine. You measure, let's say, 60%. If you now apply this left ventricular strain, which is no longer the ejection fraction, but the active deformation of the myocardium, you see that in these patients with this hypertrophied ventricles, the strain starts to go down, specifically in the septal region of the ventricle. And this is exactly where the hypertrophy is taking place. This strain is a derivative, a functional derivative of an anatomical substrate. And the belief is, and it has been shown already in experimental studies and in some human work also, that if you have a severely hypertrophied left ventricle in the septum, fibrosis comes on an anatomical level. And we can measure that with MRI. With MRI, we can measure the extracellular volume, which is not the myocytes, but it is the replacement fibrosis, the interstitial fibrosis that eventually comes as a reaction to hypertrophy. Because as you know, the oxygen and the metabolic activity is taking place in that hypertrophied septum, but in the center, there is no good perfusion. So that is where the fibrosis, where the small scar tissue start to be formed. And so my idea as an answer to your question is that probably it's that fibrosis that relates to the development of electrical abnormal conduction and eventually ventricular arrhythmias. We've seen that already in sort of animal models, but I think that this is probably a key link to what's happening. Fibrosis formation, electrical instability, and eventually sudden death. That also fits with what you say, because we see it relatively early in the disease process. If the patient survives that, then you get all the other problems that I sketched to you. Of course, a lot of this is hypothetical, but there are more and more data going in this direction.
I wish we had more time to talk about it. Excellent thinking and thoughts. Thank you very much for being with us.
I enjoyed very much. Thank you again.
Thank you again.
Bye-bye.